Good evening, everybody. I'm Dr. Rick Lehman, and this is In Your Corner with CORA. And we again have an all-star group talking about baseball injuries. And baseball is just getting underway, maybe not in the major leagues, but in little leagues and high schools, et cetera, all over the country. I think we're going to be seeing baseball as we come out of this pandemic. And I think we're going to see a lot of baseball injuries because kids really haven't had a chance to train. Kids haven't really been outside throwing and doing what kids do in the summer, spring and the summer. So we expect to see a significant number of overuse injuries coming into this baseball season, this 2020 baseball season. So I'm going to have everybody introduce themselves, starting with Tyler Kelly. Tyler, fire away.
Hey guys, Tyler Kelly here. I'm Senior Clinic Manager with CORA up in Virginia, licensed physical therapist and also an athletic trainer. My background with baseball playing goes up through high school, where I was mostly a catcher. And then I've also worked with college baseball teams on the athletic training side of things.
Dalton Schumer.
Hey guys, my name is Dalton Schumer. I'm a physical therapist in CORA's St. Louis region in Arnold. Played collegiate baseball at Maryville and just got a true passion for baseball.
Jim.
James Silvestri, I'm a physical therapist and senior clinic manager in East Tennessee. Owned a baseball academy in Louisiana for about 10 years. Have a passion for baseball injuries.
Zack.
Hey guys, my name is Zack Kelly. I am currently a professional baseball player. I spent 1 year with the Oakland Athletics and 2 years with the Los Angeles Angels. Now I'm currently scheduled to get Tommy John surgery in the next few weeks, so I'll be going through all the rehab with that as well.
So to start out, we're going to talk about, as we obviously have made clear, baseball injuries. Zack, kind of walk us through the whole story, when your elbow started getting sore, what kind of happened, how you found out you had a ulnar collateral ligament injury, and kind of the process, what treatment you've had leading up to this, what the recommendations have been, et cetera.
Yeah, well, so our minor league season ended in September of 2019, and every offseason I always take at least two and a half months off. So I got throwing again towards the end of November. And my main goal for this past off season was I wanted to add a curveball to my arsenal. And I think I probably started a little bit too early. I probably should have waited till a little bit later in my ramp up throwing program before I started to do that, but I didn't. And so I felt a little bit of a pull just going through, just an interval throwing program probably about the end of December. Then I took a week off, and then it kind of came back a few weeks later. But during my bullpens, my velocity was normal, and there was no issue there. So in my mind, I thought it was just, maybe it's just I haven't thrown in a while. It's just a little sore. So I didn't really think much of it. And then I got out to spring training with the Angels in February, and the fourth or fifth day, I was throwing a live BP and felt the same discomfort again. And then same thing, didn't really think anything of it, just try to get through it. Then about 2 days later, I couldn't throw past 75 feet. And so from there, I just went straight to our training staff, got an MRI, and come to find out I had a tear of my ulnar collateral ligament. It detached from the ulnar bone. And
rehab, no rehab? Did they just say, hey, you need to have a Tommy John reconstruction, or what happened from there?
Yeah, well, it was a partial tear, so it wasn't a complete tear. So, in my mind, this is, end of February, I'm trying to win a job. So I elected to go the rehab route. The rehab route that the Angels set up for me was we're going to take 4 weeks off, completely no throw, and then we're going to implement a return to throwing program. So I began the throwing program probably around end of March, early April. And I went through that for about 4 to 5 weeks. And it started off really well, but once it got to the point where I'm trying to throw 80, 90%, I knew there was no way I was getting back up to where it was, and that I needed to to go in and go ahead and get the surgery, so the rest of my career wouldn't be over.
Very good. And did you have a drop in your velocity, or was it just you couldn't throw it 100%, or did you feel your location was off? Kind of what was lacking?
Well, the velocity actually went up, which I don't know if that was a product of, you know, all the training I did in the off season or what, but the normal signs that you usually see with the Tommy John, where, you know, it's a decrease in velocity, decrease in control, they didn't really show up right away. So that's what kind of made me hesitate to get checked out. But the more and more I let it go, I couldn't really feel like I could get behind the ball, I guess, so to speak, get through the ball as well as I would like to. And the more and more I threw, the less I could really control where I wanted the ball to go. So that's when I kind of knew.
Thank you. All right, Tyler. So we're going to jump right in here. I think starting out, talk to us about the stresses on the medial elbow and the anterior shoulder. So labrum, ulnar collateral ligament in the process of throwing. And it doesn't matter if you're a catcher or pitcher or third baseman, but generating torque in your upper extremity. Explain the stresses, what happens.
So going on kind of talking about Zack's injury a little bit, I'll start with the UCL. The force that is applied to that is when you come through the external rotation part of the motion, the UCL attaches the humerus and the ulna. As you come back through external rotation, most human beings have somewhere around this range. Pitchers have about another 40% beyond what I have, because they have to create so much range of motion to create the velocity coming forward. They have even more force on the elbow than the average person. Therefore, you get a tugging sensation on the UCL on the medial side of the elbow right here. As you come back, it pulls. Excessive force on there over time can be enough to tear, partially tear, or avulge the ligament from either of the bones. The anterior shoulder, kind of similar. As you come back through external rotation, you get a little bit of separation here in the front of the shoulder, where that causes excessive stress. And both injuries most commonly come with a lot of repetitions and overuse, but then there's generally one instance where there's a high velocity pop that's associated with it, and generally an athlete will know when it occurs.
I think that's right. I think if you look at the biomechanical studies, every pitch above about 85 miles an hour puts 100% of torque on the ulnar collateral ligament. So you can tear a UCL at any time with any one of those pitches based on that element of throwing or that aggressive throwing. So I think we know it can be an overuse repetition type of problem, or it can be, as you said, one pitch, get a little tingling in your fingers, and generally the pitcher walks off the mound and says, goodbye, I'm done, you know, something happened. All right, Dalton, so we're going to talk a little bit about the labrum, the glenoid labrum, and what I'd like to ask you are about the biomechanics of the biceps, biomechanics of the bicep stress in the superior labrum when you throw a baseball. And again, it could be a pitcher, it could be a catcher. Generally, those are the two. We sometimes see it in third baseman, shortstops, but generally pitchers and catchers. What are the mechanics of the biceps?
Okay, so just to kind of segue off of what Tyler was saying there, when those pitchers go into layback, okay, that arm bone likes to rotate back, and when it rotates back, it also likes to jut forward a little bit and slide forward. So the rotator cuff muscle sitting there, but also in the front of the shoulder comes the bicep tendon, and the bicep tendon kind of serves as like an anterior support to prevent too much moving forward, and the biceps also attaches into the labrum. So the biceps is actually very active in supporting the shoulder joint and providing some stabilization, but it also makes it very susceptible to injury as well.
Excellent. So I think that's right. And I think one of the things is the biceps basically is stress and deceleration. So the labrum is pulled in deceleration, and we see these superior labral tears. And I will tell you then, if you take 20 pitchers that are asymptomatic and you get MRI of every one of them, we're going to have some degeneration of the labrum. That's just part of what happens when you throw. So Jim, I'm going to give you kind of a tough question here. Tell us about the modes of treatment, maybe the rehab and other modes of treatment for superior labrum tears, what we call slap tears, superior labrum anterior to posterior. in a throw, and again, it could be a pitcher, it could be a catcher, etc.
Right. So, I mean, these types of tears, again, through repetitive use, excessive stress, or velocity has a lot to do with that. But there may be some underlying issues that go along with that. And this, through the course of time, they may develop capsular limitations where the joint capsule on the shoulder gets tight in one particular area. They may have other issues that may be contributing with their hips, with their core, with their legs, that may also be contributing to more stress to the shoulder region. So when we're looking at this patient who has a slap tear, it's not just looking at the shoulder. We're looking at other areas of the body for potential issues. Could be the thoracic spine, again, a lack of rotation. Having limitations in your lower half, even a 20% reduction can lead up to maybe a 35% increase in stress across the shoulder. So we got to try to find maybe an underlying cause that may have precipitated this. So initially, you're just working on getting the player out of pain, restoring a lot of the mobility, dynamic mobility, as well as improving dynamic stability of the shoulder, of scapula, as well as the rotator cuff, and then working towards the rest of the body. So you got to look at the entire player with these types of injuries. And then eventually you can get to a throwing program, but again, a graduated program, and it's all based on the individual. Every player is a little different. You can't assign them all to a specific one type of throwing program. That all has to be adjusted for the player and their particular type of throwing.
Excellent. So Tyler, back to you. You're going to love this. Tell us what predisposes a pitcher to tearing their ulnar collateral ligament. Is it pitch count? Is it curveballs? Is it velocity? Why does a healthy 21-year-old athlete tear their UCL or their Tommy John ligament?
I mean, just kind of go back to what I said with the first question is it's going to be the excessive force on there, but what's going to predispose them is, depending on the age of the athlete, you're going to look at their previous throwing history. At a younger age, did they stress it a little bit earlier? I mean, we're not telling kids to throw a curveball until they're 14 years old now, and we're asking them not to throw a slider until they're 16. So we want to make sure that with these athletes, that if they're younger, if we're looking at a young tear, someone who's 15, 14, in that range, we want to make sure they weren't throwing the wrong pitches at the wrong time. With our older athletes, we want to go through a biomechanical screening to see if there's anything that we can change. Kind of like Jim was just saying, a lot of times we see the pop, we feel the pain at the elbow, but that's not where the problem was. The problem could have been, on the complete opposite side of the body. And we need to look at every angle we can with them to make sure that, are their hips rotating properly? Are they having to create excessive motion at the elbow to compensate for the fact that they're not rotating properly? It's going to take a whole assessment of the whole body to kind of figure out where this is coming from. So to prevent it, how can we prevent this? Is we don't want to just train the arm and make sure we have good motion and good strength and velocity. We want to focus on the core, the hip rotation. We want to focus on hip strength, push off, make sure that we're not going to have to compensate, with a tiny little ligament for, some muscle imbalance somewhere else.
I think the kinetic chain is so important, and everybody's kind of touched on it. And I really think that's important to understand how that kinetic chain works. You talk about hip rotation, opening up, arm slot, etc., and all these go hand in hand. So I think that was excellent. To give Zach a little preview, Dalton, of what's coming, let's talk about the steps for the rehab of a Tommy John reconstruction. What can he expect?
Well, the good news is it sounds like his wasn't completely torn. So it sounds like he's gonna be, going through less of a duration as far as the rehab process goes. But to get back to it, he's going to be looking through just some range of motion on the early end of things. He's going to be immobilized to start, right? He's going to have a brace, but they're going to work on, the wrist range of motion, and then slowly integrate into the elbow. And with time, as time goes on, start to do some very just simple, external rotation, internal rotation, then start getting to the shoulder blade muscles. And then as time goes on with that, probably more the 6 to 8 week window, we start to do more like composite movements, some more, some simulated, throwing type exercises. And then, we get to like the 9th and the 14th weeks, we start to get more plyometric, start doing more eccentric and power-based stuff. And then outside of that, it really just gets back to preparing this guy to throw. Obviously, that's his job. That's what he's going to be doing. So we've got to prepare the body as such. So.
Excellent. Zach, give us, are you going to have a conventional Tommy John? Are you going to have an internal bridge? Have they talked to you about what your surgery is going to be?
Yes, they have. Luckily, my tear was just very minimal, so I will be getting the UCL repair with the internal brace.
So you can expect, as Dalton said, this is going to probably move along quite a bit quicker than a conventional autograft. And what that is suturing your tendon, for those everybody listening out there, and then using fiber tape with an anchor at both ends to augment that repair. And we haven't done a lot, maybe 40 of those, and it's been a good operation. It's a fairly new procedure, and for partial tears, it's brought people back much quicker. So that's good news to hear. So Jim, I'm going to ask you probably the hardest question, and I want you to explain to me posterior medial spurring, which you do see in throwers very commonly, in its relationship to stresses on the medial aspect of the elbow. And more specifically, athlete comes in, he's having posterior elbow pain, not medial elbow pain, he's having posterior elbow pain. You get an x-ray, you see a big posterior spur in the olecranon. What do you do? How do you treat that rehab-wise? And if you do surgery, what are the concerns?
Well, yeah, I mean, try to treat it conservatively. You understand from the mechanics standpoint of how during leg cocking through acceleration to release point, and through extension of the elbow, you get those medial shearing forces, which then tear at the UCL and eventually cause some inflammation and spurring, like you talked about in that posterior medial fossa. They can be tough. Lack of motion. At this point, you're just trying to restore motion. You're trying to restore strength around the elbow. And then again, working towards the rest of the body, trying to again figure out what's creating those excessive stresses at the elbow. And a lot of this, going back to Dalton, working on those mechanics, video analysis, I think, is extremely important for these guys at some point, trying to figure out where the problem is. Now, the thing is, if the spurs are big enough and we're not getting anywhere and they're still having pain, it doesn't matter what we do. And they have to have surgery, and they have to have the removal of spurs. Again, removal of too much of the material, the bone in that area, can destabilize the elbow even more, where you can have further degradation of the UCL, and that just worsens the condition. That can even lead to more ulnar neuritis issues or cubital tunnel issues as well. So you got to be careful during that you only remove just the spurs. That's correct, right?
That is
absolutely correct, right? I'm near the surgeon, so you know, man.
Well, you got to be careful. I mean, I think before we knew this, we take off a little bit too much of the spur, and then the next thing you know, we see medial elbow laxity, and we couldn't understand.
Right.
Of course, people have biomechanically figured this out. And if I feel like I have to take off too much of the spur, I'll go ahead and I'll put in a brace, an internal brace with some fiber tape, just to augment UCL, so we don't have to go through this, because that rehab is really 6 to 8 weeks. That's a very short rehab.
Right.
So one thing I want to say is, Zach, good luck. You can always call Tyler and ask him what's going on, or Jim or Dalton, and they can kind of walk you through it a little bit, but I think you'll do awesome. Have a great career, and I want to thank everybody tonight. This was absolutely outstanding. I think very informative, and you guys have obviously great passion for baseball. So thank you very much.
Thanks, Dr. Lehman. Appreciate it.
Thank you.
Perfect.